So, a very good evening to all my dear friends who have joined here. So, today we are going to discuss about this calcium regulation and bone physiology. So, most of you would have started following all our schedules, and in that, from this week onwards, we will try to cover as a lecture all those topics whichever Balaji is putting. I'll try to cover it as a lecture so that it will be useful for everyone. So, with that note, I would like to start now. So to start with, today the topic was bone physiology. Whenever we tell bone physiology, it is going to involve three important hormones and important mineral, that is your calcium. So in the calcium metabolism தான் நம்ம bone physiology அப்படின்ட்டு ஓவராலா நம்ம சொல்றோம். அப்ப இந்த bone physiology அப்படின்னு நம்ம ஸ்டார்ட் பண்ணோம்னா, first we have to understand calcium metabolism in our body. So இது Thursday இன்னைக்கு உங்களுக்கு வந்து பாத்தீங்கன்னா calcium metabolism அப்படின்னு biochemistry topic இருக்கு. More or less both are going to overlap, but biochemistry we have Dr. Suganti ma'am who is going to take on Thursday. So idhiliyum there will be some topics that are covered from your biochemistry. Never mind, you can just learn it and understand the concept so that it is going to be very useful for you to learn. Okay, well, shall we go through? Can all those who are present in the Zoom, can you just put a message in the chat box? Whether can I start with the topic? Right. Okay. So let me start with. When I start with this calcium metabolism, first thing what I have to understand is what is the normal value of calcium in our body. Normal value of calcium is 8.7 to 10.2 mg per deciliter. இது வேற வழியே கிடையாது. You should mug up only. Okay, 8.7 to 10.2 mg per deciliter. You have to mug up. You don't have any choice. Okay, next is total calcium level. So whenever you just see total calcium level, so the distribution of calcium is going to be in the form of free calcium, or it is going to be in the form of bounded. Okay, free abdingade we can call it as a ionic calcium because it is going to be in a form of 2+. Okay, so the ionic calcium nu solvom. Bounded form abdingade it is going to be inactive. So எப்பயுமே ஒரு தைராய்டா இருக்கட்டும், anything whichever it is free, அதுதான் வந்து ஆக்டிவா இருக்கும். Bounded form is not going to be active. அப்ப இந்த ஃப்ரீ ஃபார்மா இருக்கு பாத்தீங்களா, the active one. So this is going to be the one which is going to have a effective action. So your calcium is going to perform its action through its free form and not through its bounded form and not through its bounded form. Clear? Okay, so now coming back to bounded form, இது வந்து எதோட பவுண்ட் ஆயிருக்கு அப்படிங்கிறது நெக்ஸ்ட் ரொம்ப முக்கியம். எதோட பவுண்ட் ஆயிருக்கு? This is going to be bounded with albumin. This is going to be bounded with albumin. So next thing what you have to understand is, okay, so you have this free albumin, you have this bounded form. So free form is the one which is going to perform its action. Bounded form, they are not going to be performing its action. அப்ப எத்தனை அமௌண்ட் வந்து அயோனைஸ்டா இருக்கு, எத்தனை அமௌண்ட் வந்து பவுண்டட் ஃபார்ம்ல இருக்கு, தென் விச் இஸ் கோயிங் டு பி காம்ப்ளெக்ஸ் வித் anion. ஸோ அது நமக்கு நெக்ஸ்ட் தெரியணும். Okay, I'll tell you. Number one, the ionized calcium is there, right? That is going to be your ionic calcium, the one which is active. So almost in your total calcium level, 50% is going to be in the ionized form. 50% is going to be in the ionized form. அப்ப மிச்சம் இருக்கிற 50% எப்படி டிஸ்ட்ரிபியூட் ஆயிருக்குன்னா, 41% is going to be in the bounded form. அப்ப 50% ionic formல இருக்கு, 41% bounded formல இருக்கு. இப்ப மீதி இருக்கக்கூடிய 1%, அந்த 9% அது எங்க போச்சு? அந்த 9% என்ன பண்ணுதுன்னா, they will be bounded or calcium, it's going to be complexed with the anions because you know it is in the form of 2+, so it can be bounded with a 2- so that they are going to be remaining inert. They can be present inert in the body. But அதுக்கு ஆக்ஷன் இருக்கா அப்படின்னு நம்ம பார்த்தோம்னா no. Okay, அதுக்கு ஆக்ஷன் இருக்கான்னு பார்த்தோம்னா no, actions are not there. இது வரைக்கும் கிளியரா? Now there is a ratio of your free form and a bounded form. அப்ப இந்த ratio of free form and bounded form who is going to control? In other terms, if I want to tell you, who is going to decide how much of free form and how much of bounded form should be present in the body? If can someone tell me? So what can be the factors that are going to be involved in the deciding authority of how many free form should be there and how many bounded form should be there? Okay va? So அதை யார் decide பண்றாங்க? Okay va? அப்படிங்கறத நம்ம பார்க்கிறோம். So ரெண்டு factor தான் which is going to decide. Okay, what are the two factors? ஒன்னு வந்து bloodல இருக்கக்கூடிய pH. Okay va? இன்னொன்னு albuminோட content. Very simple. Albumin is required to make it a bounded form. Correct? Albumin is required to make it a bounded form. So for making it a bounded form, if albumin is not available, then what happens? Free ion will be more. When there is more albumin available, what happens? Your bounded form will be more and your free form will be less. That is the first concept you have to know. Then what is the second concept you are going to understand? The second concept is you have this blood pH, isn't it? So whenever there is a decrease in the pH, that is going to be whenever your blood pH is going to move towards your acidity, what happens? So there is going to be a decreased amount of pH. That means there is an increased amount of H plus ion. அப்ப H plus ion நிறைய இருக்குன்னா அப்ப என்ன ஆகும் உங்களுக்கு? That is going to be called as acidosis. இங்க என்ன ப்ராப்ளம் ஆகுது அப்படின்னு நம்ம பார்த்தோம்னா இந்த ஆல்புமின்ல தான் உங்களோட H plus ion பவுண்ட் ஆகும், உங்க கால்சியம் அயானும் பவுண்ட் ஆகுது. அப்ப H plus ion value நிறைய இருக்கிறப்ப what happens? Your albumin doesn't get attached to the calcium. அப்ப calcium bounded formல இருக்கிற amount குறையும். அப்ப என்ன ஆகும்? Since H plus ion is going to be more, less calcium is going to be binded with the albumin. When there is a less calcium that are binding with albumin, then there is going to be increased free calcium level. There is going to be increased free calcium level in the body. அப்ப free calcium level increase ஆகுதுன்னா that is called as hypercalcemia. இப்ப புரியுதா? Why in acidosis there is going to be hypercalcemia? Why in acidosis there is going to be hypercalcemia? This is what I explained. Now coming back to the alkalosis. Alkalosisல அப்ப உல்டாவா என்ன ஆகும்? H plus ion இல்ல. அப்ப நிறைய calcium can go and bind with your albumin. When more amount of calcium binds with albumin, the free calcium level decreases in your blood. When the free calcium level is decreased in your blood, there is going to be hypocalcemia. There is going to be hypocalcemia. Third one நம்ம எங்க போறோம்னா respiratory alkalosis. So ஒரு respiratory alkalosis இருக்கு. The alkalosis terminology வந்தாலே it is going to be hypocalcemia. அப்புறம் ஏன் நான் வந்து இம்பார்ட்டன்ஸ் கொடுக்குறேன்னா hypocalcemiaல என்ன ஆகும்னா you come across this term called as tetany. You come across this term called tetany. What happens in tetany? There is going to be hyperexcitability. அப்ப whenever there is going to be low calcium ion in your body, that is going to cause increase in the sodium channel opening. அப்ப நிறைய sodium channel open ஆகும். அப்ப நிறைய sodium channel open ஆகறப்ப என்ன ஆகும்? More frequency of action potential occurs. So action potential நிறைய frequent increase ஆகும். அப்ப what happens? It is going to cause hyperexcitability. So that is what occurring in the tetany. So that is what occurring in the tetany. Is it clear? So whenever calcium ion is going to be increased, okay, more than 6 mg per deciliter. What is the normal value I told? It is going to be 8.7 to 10.2 mg per deciliter. Whenever your calcium ion number is going to go into hypocalcemia, when it is going to be less than 6 mg per deciliter, what happens? It is going to be causing tetany. What happens in tetany? Because of the hyperexcitability. Because of the hyperexcitability, there is going to be, when you're going to tap in the facial nerve. So you know the facial nerve course, isn't it? So on the course, when you're going to tap it, what happens? There is going to be a hyperexcitability of your facial nerve. Facial nerve supplies facial muscle. Therefore, there is a hyperexcitability of your facial muscle, and because of that, there is going to be twitching of your facial muscles. Because of it, there is going to be twitching of your facial muscle. This is called as Chauvet's sign. This is called as Chauvet's sign. This is the important MCQ that is asked in your examination, not only in your university, but also when you go for an entrance exam, Chopstick sign is going to be asked more frequently. Now you can understand what is the basic physiology behind it. So it's very simple. When you're going to go for a general medicine in the final year, same thing you're going to write under hypothyroid, hypocalcemia. So whenever there's hypocalcemia, what happens? There is going to be a presence of Chopstick sign. Adhaan neenga signs and symptoms la eluduveenga. Similarly, when you are going to raise the BP cuff, okay, BP cuff podrenga, pressure increase பண்றீங்க. இந்த pressure எதுக்கு மேல இருக்கணும் அப்படின்னு பார்த்தோம்னா systolic blood pressure க்கு மேல, when you're going to raise your blood pressure cuff, okay, your BP recording cuff, and you're going to keep it for 5 minutes, what happens is there is going to be a carpopedal spasm. Carpopedal spasm. This is called as Trouss's sign. This is called as Trouss's sign. So நீங்க ரெண்டு சைன் மறக்கவே கூடாது. In your hypothyroid, in your hypocalcemia, what are they? Chopstick sign ஒன்னு, Trouss's sign ஒன்னு. இது ரெண்டும் மறக்கவே கூடாது. Is it clear? Okay. Now I'll go for this. இந்த concept clear? Okay. Can someone respond in the chat box? Till now everything is clear, right? Shall I move into the next segment of this discussion? Kindly put in the chat box so that I can continue with the next segment of the discussion. Yes, thank you. Thank you, Derek Jotam Ji. Thank you. So now listen. So you know that you understand that the free calcium ion is what? That is going to be active in your body. Okay, then what are the things that are going to regulate your calcium ion? So there are 3 hormones, 3 organs. Okay, so remember like this, you have 3 hormones, you have 3 organs. So 3 hormones, one parathyroid hormone. Number 2 is your vitamin D. Number 3 is your calcitonin. Again, repeat along with me. 3 hormones, parathyroid hormone, vitamin D hormone, then you are going to be calcitonin. Vitamin D acts as hormone here. So, I vitamin D hormone அப்படிங்கிற லிஸ்ட்ல சேர்த்திருக்கேன். So, parathyroid, vitamin D, calcitonin. Idhila parathyroid and vitamin D are going to increase the calcium level, whereas calcitonin is going to decrease your calcium level. Idu varaikkum clear? Now, 3 organ now vechukkom. Okay, what are the 3 organs you are going to remember? Number 1, okay, your bone. So bone, B for bone. Okay, so what does B stands for? Bank. So your bone is going to be acting as a bank for calcium. Your bone is going to act as a bank for calcium. And diet. Diet nanadu your absorption. So factors that are going to be affecting the absorption of calcium from your GIT, that is going to be the second organ. And third thing is going to be a kidney that is going to excrete the excess of calcium. So these 3 are going to be a major factor that are going to involve in the regulation of your calcium ion. Now, moving back to the important discussion, that is going to be your bone. Okay, so this topic itself we started with the bone, isn't it? Appa இந்த bone அப்படிங்கிறது என்னது? ஆல்மோஸ்ட் வந்து பாத்தீங்கன்னா ஒரு ஹியூமன் பாடியில இருக்கிற போன் டோட்டலா கனெக்ட் பண்ணோம்னா it is going to be having approximately 1100 gram of calcium. It is going to contain 1100 gram of calcium. இதுல 99% of your calcium are going to be residing in the bone. So 99% வந்து பாத்தீங்கன்னா they are going to be residing in the bone. Okay, இப்ப இந்த calcium என்ன பண்ணும்னா போன்ல they are going to be present in the form of, it is going to be present in the form of hydroxyapatite. Okay, it is going to be present in the form of hydroxyapatites. Okay, so it is going to be in the form of hydroxyapatite. Clear? So your bone is going to be having 2 important components. One, you're going to have an organic matrix. One is going to be your organic matrix and second one is going to be your bone salt. Okay, organic matrix and bone salt. The organic matrix is otherwise called as osteoid. Organic matrix is otherwise called as osteoid and you're going to have a bone salt. Okay, இப்போ இந்த organic matrix வந்து பாத்தீங்கன்னா they are nothing but unmineralized portion. So they are going to be unmineralized portion. Okay, so this is going to be consisting of 90 to 95%, which is going to have collagen type 1. So what it is going to be containing? So it is going to be consisting of type 1 collagen. Clear? That tavira, it is going to have numerous proteins. What are the numerous protein is going to have? Albumin, thrombospodin, osteopontin, fibronectin, proteoglycans. Anjana vachkana. Again, repeat along with me. Albumin, thrombospodin, osteopontin, fibronectin, and your proteoglycans. In the anju when the organic matrix la present we call it as a unmineralized. Whereas your bone salt is going to be mainly consisting of hydroxyapatite. Okay, hydroxyapatite crystals, calcium phosphate hydroxyapatite. This is magnesium, sodium, potassium, carbonate. So if overall bone, your bone can be divided into two types. Okay, one is cortical bone, இன்னொன்னு trabecular bone. One cortical bone, இன்னொன்னு trabecular bone. What is your cortical bone? It is otherwise called as compact bone. Okay, that is the outer layer of your bone. Okay, so they are going to be constituting 80% of your bone. Okay, so they are going to be receiving your nutrition through Aversian canals. So again, the nutrition Aversian canals. Have you seen Aversian canals in the bone? So you will have a dissection table. Dissection table you have bone. Adila nutrient artery oda entry point everyone can be seeing, especially in your femur. So tomorrow when you go to a dissection hall, or femur eduthu parunga adila nutrient artery oda entry irukum. So adu valiya da ungalku enna agudna cortex ku nutrient supply agudhu. Okay va. So idila enna collagen main ah irukuna type 1 collagen da irukum. In the type 1 collagens enna pannuna, they are going to be arranged in a concentric layers. So they are going to be arranged in a concentric layers around these canals, Aversian canal sutti, that is going to form your osteon. Okay, now coming to the trabecular bone, they are going to be called as cancellous bone. So trabecular bone is otherwise called as cancellous bone. Okay, they are going to be constituting 20% of the bone, and in the cancellous bone now they are going to be metabolically active bone. So this is metabolically active bone. Okay, this is a doubt. Anyone, any doubt till this point of time? So now moving back to this bone basic taniya nama paakanona bone la ivladha. Okay, so nethike anatomy of bone you might have read it. So adha nama anatomy of bone la cancellous bone, cortical bone idu maidha nama padipom. So when you talk about physiology, physiology always deals with the hormonal actions. Appa inga nama enna hormone paakrom? I already told you 3 hormone, 3 organ. So parathyroid, vitamin D, calcitonin, and the side la bone, GIT, kidney. Okay, now coming back to the parathyroid hormone. You all know that parathyroid hormone are exclusively from the chief cells of your parathyroid gland. So they are going to be a peptide hormone. So what are they? They are going to be a peptide hormone, and they are going to be having 84 amino acids. So what are going to be there? It is going to be consisting of 84 amino acids. Clear? Okay, so what are the actions of your parathyroid hormone? I'll tell you. So talking about the parathyroid hormone, you're going to have a bone. Okay, this bone is going to have 2 cells. What are the 2 cells? One is osteoblast, other is an osteoclast. Osteoblast are going to be bone forming one. Osteoclast are going to be bone resorption. So it is going to help in bone resorption. So where is this osteoblast? So osteoblast are the one which are responsible for secretion of organic matrix and the mineralization. So they are derived from the mesenchymal cells. So they are going to be derived from the mesenchymal cells. So you need important transcription factors for the osteoblast development. Okay, you need important factors for osteoblast development. What are the important factors you want to know for developing osteoblast? Number 1, you need to have a RUNX2, RUNX2. It is one important which is required for the osteoblast formation. Second thing is bone mineralomatrix. Bone mineralomatrix protein. Number 3 is going to be your Indian edge corn. Okay, Indian hedgehog. So இது மூணு பேருமே they are important for the production of osteoblast. எங்க osteoblast produce ஆகுது? Osteoblast is produced in your mesenchymal cells. Mesenchymal cells. Clear off? Okay, so in the RunX2 வந்து பாத்தீங்கன்னா mainly they are important to regulate the proteins inside your osteoblast. So they are important for proteins in the osteoblast. என்ன proteins-காக நம்ம பார்க்கிறோம் அப்படின்னா your main important protein, I don't want to tell all the proteins, but one important protein that are formed by the RunX2 is going to be your osteopontin. Okay va? And your second thing is going to be your type 1 collagen. Type 1 collagen may the RunX2 தான் transcript பண்ணுது. Third thing is going to be osteocalcin. Okay, இந்த மூணு மட்டும் மறக்க கூடாது. இது மூணையும் யார் டிரான்ஸ்கிரிப்ட் பண்றாங்கன்னு பார்த்தோம்னா RunX2 தான் டிரான்ஸ்கிரிப்ட் பண்றாங்க. So any mutation in this RunX2, இந்த RunX2 ல ஏதோ ஒரு மியூட்டேஷன் ஆகுதுன்னா that will lead to dysplasia. Similarly, fourth important thing that is RunX2 is transcripting is going to be your rank ligand. What is this rank ligand? I will tell you. It is a receptor activator for NF-κB. NF-kappa B அப்படின்னு நம்ம சொல்றோம். So another kappa னே சொல்றோம். RANK. So receptor activator of NF-kappa B ligand. So that is called as rank ligand. In the rank ligand is very much required. Why? I will tell you. But this rank ligand which is going to be transcripting your RunX2 is transcripting. Up to this, is it clear? Okay. Next, when you're going to move towards, okay, hormones that regulate your osteoblast formation, I told you three important things. That is your parathormone, vitamin D, and insulin-like growth factor. Now coming to your osteoclast. Osteoclast is otherwise called as bone resorption, isn't it? So அதோட வேலை bone resorption. இங்க இருந்து derive பண்றோம்னு பாத்தீங்கன்னா they are derived from the hematopoietic lineage. It is derived from the hematopoietic lineage, and who is going to be helping in the facilitating in the osteoclast differentiation. Osteoclast differentiation you need osteoblast. Ultava. So both are going to be interdependent. Osteoclast oda differentiation yaar thevapadranga. For osteoclast you need osteoblast. From the osteoblast you will have signals to differentiate your osteoclast, because osteoclast has to be low in the body, and only when it required osteoclast must be increased. Therefore your osteoblast will be giving signals for differentiation of your osteoclast. Is it clear? Okay, now what happens whenever there is going to be a osteoclast differentiation, you need someone to inhibit it, isn't it? அப்ப யார் இந்த osteoclast production inhibit பண்றாங்க அப்படின்னு நம்ம பார்த்தோம்னா it is done by osteoprotectin. ஓகேவா? சோ இதுல பேர்லயே இருக்கு, it is protecting the bone. அதனால you call it as osteoprotectin. ஓகேவா? So the osteoclast differentiation is facilitated by osteoblast and inhibited by your osteoprotectin. So osteoclast is very important for bone resorption. Specific region in the bone where your osteoclast are going to cause bone resorption, that is called as, anyone know what it is called as? Auschwitz lacunae. So எந்த ஏரியால உங்களுக்கு bone resorption இருக்கோ அதுக்கு பேர் வந்து Auschwitz lacunae. Clear? So osteoclast function is very similar to that of the lysosomes of the cell. So inside of your osteoclast is going to be highly acidic. அதனாலதான் இதுக்கு வந்து ruffled border இருக்கும். And carbonic anhydrase 2 enzyme is present inside your osteoclast, that is going to be giving necessary H+ ion. So your protease like your cathepsin is going to act at a such low pH, and it is going to facilitate the process of resorption. So whenever there is going to be a mutation in the cathepsin K, so in the Auschwitz lacuna form ஆறதுக்கு you need cathepsin K. So in the cathepsin K la ஏதாவது mutation நடந்தா it leads to phycnostenosis. So what is that called as? PKY Okay, NODYSOSTOSIS, stosis, pycnodysstosis. So pycnodysnosis pakarago. So where your osteoclasts are present but not functionally well. So adala function பண்ண முடியாது, but it will be present. Clear? So இது எதுக்காக osteoclast is required? They are very much required for the bone remodeling. So they are very much required for bone remodeling. When you're going to go outside, you're going to meet with a slip and fall. You're going to have a fracture, a mild hairline fracture. That point of time, what you need to do is you have to correct it. எப்படி correct பண்ணணும்? நம்ம body will be trying to replace the shape of the bone to its original shape. So how it will be doing? First osteoblast வரும். Osteoblast வந்து bone development ஆகும், பட் அது கரெக்டான ஷேப்ல இருக்காது. அப்ப osteoclast என்ன பண்ணும்? கரெக்டான ஷேப் கொடுக்கும். அதனாலதான் osteoclast we call it as a architect of your bone. So osteoclast இல்லனா proper shape வராது. So they are the architect of your bone. Now coming back to your parathyroid hormone. So you know that parathyroid hormone is very necessary. Why very much necessary? Because your parathyroid gland is going to act in the osteoblast. How it does, let us see. So your parathyroid hormone is going to be secreted. They are going to be coming to osteoblast. எங்க ஆஸ்டியோபிளாஸ்ட்ல எங்க இருக்கும்னா, ஆஸ்டியோபிளாஸ்ட்ல you have receptor for your parathyroid hormone. அந்த parathyroid hormone receptor கிட்ட அது வரும். So வந்து what it does is it is going to sit on the receptor. What it does, once it comes and sit, it is going to release rank ligand. இந்த rank ligand என்ன பண்ணும்னா osteoclastக்கு போகும். Osteoclastல என்ன பண்ணும்? It leads to differentiation of your osteoclast and that is going to cause bone resorption. அப்ப நம்ம என்ன பண்ணலாம்னா, when you are going to give a rank ligand blocker like your denosumab, 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 it is going to prevent bone resorption. So denosumab na enadhu? It is a rank ligand blocker. Whenever you are going to give a rank ligand blocker, it is going to prevent the bone resorption. That is the reason why we use it in the osteoporosis. Now coming back to your parathyroid hormone. So what is this parathyroid hormone is going to be present? So in a normal person, normal plasma level of your parathyroid hormone is going to be 10 to 55 picogram per ml. It is going to be off-life of 10 minutes. Off-life normally 10 minutes. Okay, now coming to the regulation of secretion of your parathyroid hormone. Normally, parathyroid hormone enga secrete ஆகும்னு பார்த்தோம்னா, whenever there is going to be a calcium நிறைய இல்லாம போறப்ப, that is hypocalcemia. So when there is hypocalcemia, there will be increase in the PTH secretion. Whereas when there is high calcium level, they inhibit the secretion of your parathyroid hormone. அப்ப அல்டிமேட்டா உங்களோட extracellular fluidல இருக்கக்கூடிய calcium level தான் is going to determine the parathyroid hormone secretion. Clear? Now calcium is going to regulate your parathyroid hormone secretion சொல்லிட்டோம். அப்ப எது மூலமா your calcium is regulating your parathyroid hormone? By calcium sensing receptor. So you need someone who is going to sense, isn't it? அவங்க தான் வந்து calcium sensing receptor. So he is going to be the calcium sensing receptor. So calcium sensing receptor is a G protein coupled receptor which is present in the chief cells of your parathyroid hormone. Normally, your calcium acting through this receptor will be inhibiting your parathyroid hormone secretion. So automatically calcium level கம்மியா இருந்ததுன்னா inhibition போயிடும். அப்ப parathyroid hormone is going to be increasingly secreted. ஓகேவா? வேற எங்கெல்லாம் உங்களுக்கு வந்து பாத்தீங்கன்னா there is going to be calcium sensitive hormone receptor. ஓகே, எங்கெல்லாம் இருக்கும் அப்படின்னு பார்த்தோம்னா, it is going to be present in the calcitonin producing C cells of your thyroid and it is present in the renal tubules. It is present in the brain. Clear? இது வரைக்கும் ஏதாவது டவுட் இருக்கா? Now moving towards your bone. So bone என்ன இருக்குன்னா, you have this osteoprotectin. I already told you this osteoprotectin is produced by osteoblast and they're going to protect and prevent the bone resorption. Thus PTH indirectly causes bone resorption. So now your parathyroid hormone comes, it is going to be sit on your osteoclast. Osteoclast la enna pannu, they dissolve your calcium phosphate crystals that are present. So a calcium phosphate crystal, or you call it as hydroxyapatite crystals. When these hydroxyapatite crystals are broken down, it is going to be causing increase in the calcium ion. It is going to be causing increase in the phosphate ion. So ரெண்டு ion release ஆகுது. என்னன்னா ஒன்னு calcium ion, இன்னொன்னு phosphate ion. So இப்போ parathyroid hormone continuous administer பண்ணீங்கன்னா bone resorption ஆகும். ஆனா இதே parathyroid hormone when you are going to give it in a intermittently, how what happens? It is going to promote bone formation. How? Anyone? PTH கம்மியா கொடுத்தா it is going to promote bone formation. அதே PTH நிறைய கொடுத்தா it is going to continuously கொடுத்தா it is going to cause bone resorption. How is this occurring? Correct na கேக்குற கேள்வி. So why is this occurring? This has to be coming in your mind. So now I will tell you how it is going to do. Okay va? So your parathyroid hormone, calcitropic hormone increases serum calcium level. Correct தான். ஆனா அது என்ன பண்ணும்னா, since the bone resorption cells osteoclastic receptor இல்லாதனால osteoclast வந்து osteoblast மூலமா தான் activate ஆகுதுன்னு சொல்றோம். But what happens is intermittent administration of your PTH will be causing a increase in the it will be causing increase in the bone formation rather than bone resorption. Okay va? So it is going to be causing bone resorption. ஏனா intermittent administration of PTH என்ன பண்ணும்னா will lead to a net stimulation of your bone formation. So intermittent கொடுக்கறப்ப என்ன ஆகும்? உங்களுக்கு வந்து PTH கொடுக்கறப்ப intermittent கொடுக்கறப்ப calcium ion ஓட லெவல் என்ன ஆகும்? calcium ion ஓட லெவல் இன்க்ரீஸ் ஆகும். அப்போ உங்களுக்கு hypercalcemia பாடியில வந்தா என்ன ஆகும்? hypercalcemia will be leading for a feedback mechanism. So hypercalcemia will cause a feedback mechanism. Because of it, it is going to be promoting bone formation whenever there is an excess of calcium in the blood. அப்ப intermittent நீங்க கொடுக்கறப்ப it is going to helpful in bone formation rather than bone resorption, and that is the concept which we are using in the osteoporosis treatment, where we give teriparatide. It is a recombinant combination of parathyroid hormone. When you give 20 mcg subcutaneously once a day, it is going to be helpful in treatment of osteoporosis. Clear? Now what happens in your kidney? அப்ப நம்ம மூணு இடத்துல நம்ம ஆக்ட் ஆகுதுன்னு சொன்னோம். ஒன்னு போன், இன்னொன்னு கிட்னி, ஒன்னு GIT. இப்ப போன்ல என்ன ஆகுதுன்னு நம்ம பார்த்துட்டோம். Next we are moving towards the kidney. Till now is it clear? Okay, what happens in your kidney? I'll tell you. In kidney, the parathyroid hormone is going to cause phosphate excretion. Okay va? Your parathyroid hormone is going to cause phosphate excretion, but unfortunately your parathyroid hormone will be causing increase in the resorption of the calcium ions in your distal convoluted tubule. Proximal convoluted tubule la phosphate excretion நிறைய ஆகுது. அது distal convoluted tubule la all your calcium are going to get reabsorbed. அப்ப your parathyroid hormone is going to act on the proximal convoluted tubule. It is going to inhibit the sodium phosphate co-transporter. So this is going to cause increase in the phosphate excretion. So thus overall action என்ன ஆகும்னா your PTH phosphotonin எப்படி வேணா சொல்லலாம், that is going to cause increase in the calcium ion but decrease in the PO4 phosphate ion. Increase in the calcium ion but decrease in the phosphate ion. அதனாலதான் we call it as phosphatouric action. It is going to have a phosphatouric action. Now coming to the action in the GIT. GIT la the parathyroid hormone direct act பண்ணல. Ultava, it is going to act through vitamin D. Since your parathyroid hormone increases the calcium secretion absorption in intestine by stimulation of production of vitamin D. நிறைய vitamin D produce பண்ணோம். And the vitamin D நிறைய produce ஆகிறதுனால there is going to be increase in the calcium hormone. So remember, only hormone that is going to increase the calcium ion absorption in your GIT is going to be your vitamin D. Okay va? So but இங்க என்ன ஆகும்னா உங்களுக்கு calcium absorb ஆயிடும், but இங்க phosphate observe பண்ணாது. அப்ப what happens? There is an increase in the calcium, but there is a decrease in the phosphate. There is an increase in the calcium, but decrease in the phosphate. So most important stimulus for the release is going calcium ion levels தான். ஓகேவா? So remember, இந்த vitamin D வரணும்னா அதுக்கு most important factor that is going to be helpful in release is going to be your decrease in your calcium level. Whenever there is an increase in the calcium level, it is going to be automatically by a mechanism of reverse feedback mechanism. There is going to be a suppression of your PTH. So, அப்ப PTH suppress ஆகுதுன்னா எப்படி அதை sense பண்ணுது? Calcium sensing receptors. I already told you this mechanism. Calcium sensing inactivating mutation will be causing PTH is not going to be suppressed. ஓகேவா? இப்ப ஒருவேளை இந்த calcium sensing receptorல வந்து ஏதோ ஒரு mutation நடக்குது. இந்த மாதிரி ஒரு mutation நடக்கிறப்ப your PTH is not going to get suppressed. So that condition is called as familial hypocalciuric hypercalcemia. Okay, so familial hypocalciuric hypercalcemia is due to the inactivating mutation of your calcium sensing receptor. Because of this mutation, there is going to be exaggerated PTH secretion that is going to be leading to hyperparathyroidism like state. Okay, this condition will be characterized by enhanced renal calcium resorption that is going to lead to hypercalcemia. Okay, that is going to be lead to hypercalcemia. Okay, right. இப்போ ஒருவேளை உங்களுக்கு இந்த familial hypocalciuric hypercalcemia what happens? There's an inactivating mutation of your CASR. அப்ப இந்த CASR எந்த drug activate பண்ணும் அப்படின்னு நம்ம பார்த்தோம்னா you have this drug called as cinacalcet. You are having a drug called as cinacalcet. CINA calcet. So what this cinacalcet does? Okay, so it is going to be inhibiting your parathyroid hormone secretion. Romba simple. So it is going to inhibit your parathyroid hormone secretion. Clear? So now rendu hormone or organ nama paathutom vitamin D. We have seen the entire PTH hormone. PTH hormone action on 3 places. One kidney, one bone, இன்னொன்னு GIT. Okay, next நம்ம என்ன பார்க்கணும்? Vitamin D பார்க்கணும். In between this, if you have any doubt among this parathyroid hormone actions, you can just message it in the chat box. Otherwise, we can move towards the next one, that is vitamin D. Is it clear? Can someone message in the chat box? Till now, is it clear? Shall I move into the vitamin D? Someone can kindly can message it in the chat box so that I can move it to the next one. Thank you, thank you. So I'm moving towards the next one, that is going to be your vitamin D. So vitamin D, we otherwise called as sunshine vitamin. Why I am telling it as a sunshine vitamin? எல்லாருக்குமே நம்மளோட ஸ்கின்னுக்கு கீழே 7-dehydrocholesterol, that is your vitamin D3 is present. Okay, but this vitamin D3 is needed to get converted to an active form. So this vitamin D3 is an inactive form. அப்ப இத active form convert பண்ணனும்னா அது breakdown ஆகணும். அப்ப இந்த breakdown யார் பண்றாங்கன்னா UVB rays which is present in the sunlight. That is why I call it as a sunshine vitamin. That's why I call it as a sunshine vitamin. Clear up? So you have a skin. Okay, you have a precursor of the skin. This precursor is 7-dehydrocholesterol, not vitamin D3. Once your sunshine comes, UVB light comes, it is going to get breakdown, and this breakdown product of your vitamin D3 are going to get circulated. They are going to enter your liver. When it enters your liver, you're going to have 25 hydroxylase. You're going to have 25 hydroxylase. So this 25 hydroxylase is going to convert this 7-dehydrocholesterol to 25 hydroxy vitamin D3. This 25 hydroxy vitamin D3 is the one which we are going to see in the lab, which we are going to be measuring. So உங்களுக்கு vitamin D3 ஓட level பார்க்கணும்னா, vitamin D ஓட level பார்க்கணும்னா எதை நீங்க measure பண்ணுவீங்க? 25 hydroxy vitamin D3. That is what you are going to measure. Okay, now you have this 25 hydroxy vitamin D3. Now next question, in the 25 hydroxy vitamin D3 is the active form அப்படின்னு கேட்டீங்கன்னா இல்ல. This vitamin D3 form, which is present in the liver, is not active. It is not active. So appa adha nama enna pandrona, we are going to go through the kidney. Kidney la enna panadana, you have this 1-alpha hydroxylase enzyme, 1-alpha hydroxylase enzyme that is going to convert this 25 hydroxy vitamin D3 to 1,25 dehydroxy vitamin D3. So you are going to get converted that into 1,25 dehydroxy vitamin D3, otherwise called as calcitriol. So what you understand from this, you have this calcitriol, which is going to be the active form of vitamin D. This active form enga secrete agudhu? Kidney la, in the presence of alpha hydroxylase enzyme. Appa, what is the rate limiting enzyme? Your rate limiting enzyme is your alpha hydroxylase. What I understand by the rate limiting enzyme, the enzyme which is necessary for the conversion into active form. So on the active form, yaar kudukranga? Your alpha hydroxylase. When there is going to be a inhibition of alpha hydroxylase, there is not going to be active form of vitamin D3. So whenever in a CKD patient, there is going to be impairment of this process. So there is going to be reduced level of vitamin D that is necessary for the function. Is it clear? So you have to understand. Appa, where are the other places where you have 1-alpha hydroxylase? You have in the epidermal keratinocyte, you have this 1-alpha hydroxylase in your placenta, and pathologically the macrophage of your granuloma and lymphoma will be having 1-alpha hydroxylase. Is it clear? Now, who is going to stimulate this 1-alpha hydroxylase? Your PTHN, there is a decreased calcium. Whenever there is a decreased calcium ion, so you need vitamin 3. This vitamin T is going to cause increase in the calcium ion. Therefore, there is going to be a vitamin D secretion. Similarly, your parathyroid hormone indirectly acts by increasing the formation or increasing the production of your vitamin D3. Is it clear? Now coming back to, if there is a high calcium in the blood, then what happens? I already told you, the stimulation factor is going to be decrease in your calcium. Whenever there's an increase in the calcium, you don't need a vitamin D, isn't it? Appa, okay, vitamin D தேவை இல்லை. அப்ப என்ன பண்ணுனா, there is a production of 24,25 dehydroxy vitamin D. So your kidney also expresses another enzyme called as 24,25 hydroxy vitamin D. Who is going to stimulate that? It is going to be stimulated by 24 hydroxylase. It is going to be synthesized by 24 hydroxylase. Clear? So this is inactive metabolite. This is going to be inactive metabolite. Clear? Now coming to the action of your vitamin D. So vitamin D is the only hormone that is going to be acting on your GAT for a calcium metabolism. Okay, so this calcium absorption is going to be occurring in your duodenum in the presence of vitamin D. Appa, vitamin D, in the presence of vitamin D, then calcium it's going to get absorbed. What are the other factors? Verum vitamin D தான், it is a factor for absorption of your calcium. You need calbindin. You need increased expression of your calcium ATPase, and you need increased alkaline phosphatase. These 3 points are necessary for increasing the calcium absorption. Now coming to the second one, vitamin D at bone. At the level of bone, vitamin D has dual action. One, excess calcium, okay, it's going to be there. Abdina, it will be leading to bone formation. Whereas hypocalcemic state, it is going to cause bone resorption. So, okay, so when the vitamin D receptors again it is present in your osteoblast, you have this rank ligand, it is going to induce differentiation of osteoclast, and it is going to cause bone resorption. அடுத்த organ என்ன? Kidney. So kidney la enna pannuna, it is going to increase in the calcium resorption as usual. In contrast to your parathyroid hormone, which is going to cause excretion of your phosphate, here what happens? It is going to cause resorption of your phosphate. So what is the difference? A contrasting difference between your parathyroid hormone and your vitamin D is parathyroid hormone causes increased calcium resorption and increased phosphate excretion. Whereas at the level of kidney, your vitamin D is going to cause increase in the calcium resorption as well as your phosphate resorption. Clear? So this is very important concept. I told you 3 hormones. First is going to be your parathyroid hormone. Second is going to be your calcitonin. Now you have already completed parathyroid hormone. So now second thing, vitamin D is over. What is the third thing which you are going to deal in next 10 minutes? Calcitonin. Okay, wow. So calcitonin is going to be synthesized by the parafollicular C cells of your thyroid hormone or your thyroid gland. So this calcitonin is going to have a receptor. Okay, wow. Calcitonin as a receptor, not in your osteoblast. It is going to be having receptor in your osteoclast. Okay, நம்ம எப்பயுமே osteoblast ன்னு நினைச்சிட்டு இருப்போம், but it is going to be having receptor in your osteoclast. Okay, this is going to inhibit your osteoclast. So direct action instead of osteoblast la irundhu osteoclast varama மூக்க சுத்திட்டு தொடாம இது டைரக்டாவே போய் என்ன பண்ணுது, உங்க osteoclast போய் அட்டாக் பண்ணுது. So this is going to prevent your bone resorption. Okay, so this is going to cause decrease in the calcium. This is going to cause decrease in the calcium. Clear? So the drug that is going to be obtained from your salmon fish, you call it as a salcotonin. ஏன் நான் இதை பத்தி பேசுறேன்னா, இந்த salcotonin, it is going to mimic your calcitonin. But why I am talking about the calcitonin? What are the functions of your calcitonin? Remember, your calcitonin is going to cause decrease in the absorption of calcium from your GIT and your kidney. So calcitonin என்ன பண்ணுது? They are decreasing the absorption of calcium from your GIT and your kidney. Therefore, it is going to reduce your calcium level. Okay, now very important thing you have to remember is, in a mother, a pregnant mother or a lactating mother, there will be increased loss of calcium storage. Okay va? அப்ப calcium stores நிறைய loss ஆகிறப்ப என்ன ஆகும்னா, போன்ல இருக்கிற கால்சியத்தை யூஸ் பண்ணிக்கலாம்னு நம்ம physiological aspect of our body decides. But at that point of time, okay, who is going to come and save your bones? Calcitonin are going to come and save your bone. Calcitonin is going to inhibit the bone resorption. Thus, calcitonin prevents your excess bone calcium loss. Therefore, it is going to protect your bone. Okay, now another important concept you have to understand is calcitonin is produced in the parafollicular C cells. So in a medullary carcinoma of thyroid, there is going to be a malignant growth of your parafollicular C cells. This is going to produce excessive calcitonin. Therefore, calcitonin acts as a tumor marker in this point of time. So in a medullary carcinoma of thyroid, your calcitonin is going to be serving as a tumor marker. Similarly, all hypercalcemia, okay, is not just due to malignancy. Okay, in certain regions, example in a small cell carcinoma of lung, in a squamous cell carcinoma of lung, in a renal cell carcinoma, in a breast cancer, all these spaces, what happens? In all these malignancy, there is an increased parathyroid hormone related peptide. This parathyroid hormone related peptide are going to cause hypercalcemia. Okay, here the reason is not your parathyroid hormone, but the hormone that is going to mimic your parathyroid hormone, which has a related peptide. Therefore, what I named it is a parathyroid hormone related peptide. This parathyroid hormone related peptide has 4 important functions. In a normal person, what is that? It is involved in the growth and development of cartilage in your fetus. They are going to be helpful in placental calcium transport. They are helpful in development of teeth, and they are going to be preventing excitotoxic neuronal damage. Excitotoxic neuronal damage. Now coming to what are the markers of bone formation? Okay, well, finally we are going to move towards what are the markers of bone formation. Number 1, osteocalcin. Number 2, alkaline phosphatase. Number 3, propeptides of your type 1 collagen. Okay, who are going to be the markers of bone resorption? So, other renda pirichikireenga blood urine. Bloodல வந்து tartarate resistant acid phosphatase, matrix metalloproteinase, cathepsin K. இவங்க மூணு பேருமே they are required for the bone resorption. Similarly, urine la telopeptidase of a collagen cross link. You have two cross links, NC. N வந்து NTX ன்னு சொல்லுவோம் and C ஓட regionல CTX ன்னு சொல்லுவோம். இவங்க ரெண்டு பேரும் யூரின்ல இருந்தாங்கன்னா அப்போ உங்க collagen break down ஆயிருக்கு, அப்போ bone resorb ஆயிருக்கு அப்படின்னு அர்த்தம். Second thing is pyridonolin and third thing is deoxypyridonolin. Okay, wow. Now I have completed all the essential things for the bone physiology. That is going to be your calcium metabolic process. You have the parathyroid hormone secretion. You have calcitonin secretion. So I request everyone, those who are present, to open up your chat box and now tell the answers for the following question. Which is going to inhibit the bone resorption? Among these four, vitamin D is there, parathormone is there, parathyroid hormone related peptides are there. Okay, you have the estrogen also with you. Now tell me which of the following is going to cause inhibition of the bone resorption. Which are the following is going to cause inhibition of the bone resorption? Okay, come on, tell in the chat box someone. Can you type in the chat box among the four options which is going to cause inhibition of the bone resorption? Someone, quickly. Just tell one answer, no issues. So those who are present, around 5 or 6 students are present. No, you just let me know which of the following is going to inhibit the bone resorption. Which of the following is inhibiting your bone resorption? Ashwati, Derek, Jodham, Arini, Darshini, Priya. Someone, can you respond? Okay, parathormone is going to inhibit your bone resorption. Is it inhibiting your bone resorption? No. Parathormone will be promoting bone resorption. That is the correct answer. So, parathormone illa. அப்ப மீதி இருக்கிற மூணு ஆப்ஷன்ல எதா இருக்கலாம்? Someone, இந்த மூணுல எது ஆன்சரா இருக்கலாம் அப்படின்னு நீங்க நினைக்கிறீங்க? C illa, parathormone illa. Parathormone will be causing bone resorption. It is not going to inhibit your bone resorption. Very good. Estrogen is the right answer. Why I am telling estrogen is the right answer, I will tell you. This estrogen are going to cause, okay, this estrogen will be causing an increase in the osteoprotectin. Okay, it is going to cause increase in the osteoprotectin. Protect, the word meaning na sonna, it is going to protect your bone formation or bone protect பண்ணுது. அப்ப this is not going to, this is what it is going to cause inhibition of your bone resorption. மீதி எல்லாமே bone resorption பாசிட்டிவா இருக்கும். அதாவது போனை வந்து ரிசார்ப் பண்றதுக்கு ஹெல்ப் பண்ணுது. விட்டமின் டி, பாராதைராய்டு ஹார்மோன் ரிலேட்டட் புரோட்டீன், பாராத்தார்மோன், இவங்க மூணு பேருமே they are going to cause bone resorption, whereas your estrogen is the one which is going to inhibit your bone resorption. How? By promoting osteoprotectin, and osteoprotectin in turn inhibits your bone resorption. Is it clear? Next, can we go? Familial hypocalciemia is due to what? Due to inactivation of what hormone? Someone, can someone respond? Familial hypocalcemic, hypocalciuric hypercalcemia. Exactly. Correct answer is calcium sensitive receptor. Third one, most specific test for diagnosing vitamin D deficiency. Which is the most specific test in diagnosing vitamin D deficiency? Someone? Come on, if it is wrong also, there is no issue. You can just put in your chat box, right? Which is going to be the most specific test for diagnosing, which is the most specific test for diagnosing vitamin D deficiency? 1-alpha hydroxylase. I got one answer. Next, someone, if you want to try, or are you agreeing with the Answer? Are you agreeing with the answer? Okay, I am getting one more answer. 25 hydroxy vitamin D levels. Yes, 25 hydroxy vitamin D. That is your 25 hydroxylase. That is going to be the enzyme that is going to be occurring in your liver, isn't it? And the liver la enna enzyme irukko adha vandu test ki use pandrathu. I told you that is the one which we are using for that test. Appa what is the most specific test for diagnosing vitamin D na liver la nadakra and process da irukanum. Liver la irundhu varakudiya and product enadhu 25 hydroxy vitamin D. Adha answer. Then finally osteoclast has specific receptors for osteoclast la irukka receptor edu? Calcitonin, exactly, correct one. Now, finally, I am having one more question. What is this? In tetany, hyperexcitability is due to what? I am just giving a direct question. In a tetany, hyperexcitability is occurring due to what? ஏன் வந்து டெட்டானில ஹைப்பர் எக்ஸைட்டபிலிட்டி இருக்கு அதுதான் கேட்கிறோம். இது வந்து போஸ்ட் கிராஜுவேட் எக்ஸாம்ல இந்த பிஜிஐ சண்டிகர் in 2004 June they have asked this question. Okay va? In tetany hyper excitability is due to what? That was the question. The answer is why there is hyper excitability. There is hyper excitability because of low calcium. Okay, whenever there is a low calcium, it is going to cause increase in the permeability of sodium. So whenever there is a low serum calcium level, it is going to move more sodium ions into the cells. That is going to lead to frequent generation of your action potential. And because of it, there is going to be hyperexcitability followed by tetany. With this, I am concluding the topic. In just 1 hour, we have discussed only for 1 hour. In this 1 hour, we have discussed the entire bone physiology, or in other words, you can call it as a calcium endocrine of calcium, parathyroid hormone, calcitonin. இந்த 3 plus vitamin D. இந்த 4மே நம்ம பார்த்திருக்கோம். Maybe subsequently, I will one day in this week or somewhere, I will also take the clinical application of all these things. So இப்ப நம்ம physiology மட்டும் தான் பார்த்தோம். Maybe we will also discuss about the clinical application somewhere in this week whenever I am getting time. I'll just notify in the group. So I will also put this video in the YouTube. So in the comments, I will also keep the group link of this discussion groups which we are having, so that those who are seeing this video through YouTube, you can just join the discussion group, so that we will have many discussions in that group with the faculties of the subjects who will be helping you and guiding you throughout this year. Okay, thank you so much. So you can just put your feedbacks in the feedback form whichever I'm circulating after this session. So you can just put the feedback form and you can give me your comments, your suggestions, so that in the next class we can improve to the further. The ultimate aim is for utilizing the time, and you can also utilize the time and you can just read something through us. Okay, thank you so much. Thank you for participating in the today's session.